First of all, the patient is made to sit with the head straight. Then the supraorbital nerve is palpated in the supraorbital notch, which is at the junction of medial 1/3 and lateral 2/3 of the supraorbital ridge by the rolling motion. After that, the supratrochlear nerve is palpated just medial to the supraorbital nerve. For the infraorbital nerve, it is palpated against the infraorbital foramen just below the medial part of the infraorbital margin. For the zygomatic nerve, we identify the temporomandibular joint, and by swiping the hands along the zygomatic arc, a zygomatic nerve can be palpated. For the greater auricular nerve, the patient is made to look on the other side, and usually the greater auricular nerve is easily visible, crossing sternocleidomastoid muscle obliquely, passing from the lateral border to the infraauricular area. However, if it is not visible, then the patient can be asked to press against the resistance so that the sternocleidomastoid becomes tight and the greater auricular nerve can be seen. Now for the clavicular nerve, the head of the clavicle is identified and the finger is rolled against the shaft of the clavicle in order to identify the 3 sets of the clavicular nerves. Radial nerve, the patient is asked to abduct the arm to identify the insertion of the deltoid, and just posterior to it in the spiral groove, radial nerve is palpated. For the ulnar nerve, the elbow is flexed at 90 degree, and then the examiner's right hand holds the patient's right hand in shaking hand manner. After that, in the ulnar groove, it can be palpated. For this, the little finger is used to locate the nerve, and other 3 fingers are used to palpate the nerve upward along the medial border. Both sides can be palpated at a time. Now for the radiocutaneous nerve, the hand is semi-pronated and the thumb is abducted in order to make the anatomical snub box out, and the radiocutaneous nerve is palpated in this anatomical snub box by a rolling motion. Both the nerves should be palpated at a time in order to compare the two. Now for the median nerve, the patient is made to make the tendons of palmaris longus and flexor carpi radialis taut by touching the tips of the fingers, and the nerve is palpated in between these tendons. For the lateral popliteal nerve, the patient is made to sit with legs dangling freely, and then the knee is stabilized by pressing the thumbs, and then the nerve is rolled with the fingers against the neck of fibula in upward and downward motion. For the posterior tibial nerve, the medial malleolus and Achilles tendon is identified, and the nerve is palpated in between them. For the sural nerve, the lateral malleolus is identified, and just inferior and lateral to the lateral malleolus, the sural nerve is tracked along the 2 bellies of the gastrocnemius. Now for the sensory testing, first of all, the demo is done with the patient's eyes open, and patient is asked to call out a number, especially the number 1 or ek in Nepali, when he or she feels the sensation. During the sensation examination, the duration of the contact between the skin and the object that we are using should not be more than 2 seconds, and it should only be a touch rather than a swiping movement. Further, during the examination, the 10 sites recommended by WHO should be examined, and the 2 sites should be examined simultaneously, and after completing that, the proximal and the distal sites should also be compared. Since the patient might be able to know the touch sensation, however, it might be decrease in intensity, so we should compare the proximal and the distal aspect in order to confirm whether there is any sensation loss or not. To evaluate the fine touch, we use a wisp paper cotton as shown in this video.
Yeah.
China is this.
Turn money.
Tabai.
Yeah.
Tabai.
Yeah.
Bai.
Yeah. Stay up.
Usted.
Yeah.
Tabai.
Yeah.
Usted.
The 10 sites are also examined in the feet as shown in this video.
थाहा भइरहेछ छैन ए नेपाल
यहाँ के फरक छ
छैन
यहाँ
छैन
यहाँ र यहाँ यहाँ र
After completing the examination of hand and feet, the sensation in the lesional skin should also be examined in the similar way.
तपाईँले अघि छोको जस्तै यो छोको र यो छोकोमा केही फरक छ उस्तै छ
In a similar manner, the crude toss is evaluated with the help of the tip of the ballpoint pen, the pain with the help of a pinprick, and temperature with the help of hot and cold water in test tube. However, because of the resource limited settings, we could not do these tests. Now for the evaluation of the orbicularis oculi muscle, first of all, the patient is asked to close the eyes normally. While doing so, up to 2 to 4 mm gap is a normal variant. After that, the patient is asked to close the eyes forcefully, and the examiner tries to separate the eyelids. If he is able to do so easily, then it signifies lack of thymus. Now for the evaluation of the buccinator muscle, the patient is first asked to blow a whistle, then she is asked to blow, and after that the examiner taps on the cheeks in order to ensure the proper sealing of the lips. And now for the evaluation of abductor pollicis brevis and thus the median nerve, the patient's hand is laid flat on the table and then asked to touch a pin that is held slightly higher and in the inner aspect by moving the thumb vertically up, that is by abduction. For the evaluation of the opponent's pollicis muscle, the examiner stabilizes the patient's hand with one hand, and the patient is asked to swing the thumb across the palm to touch the tip of other finger. For the Osner clasping test, the patient is asked to clasp the both hand and we look for any pointing index or not. The book test, the patient is asked to hold a book between the two hands by keeping the adducted thumbs straight on its surface, and then the examiner tries to pull the book in the opposite direction. That flexion at DIP and hyperextension at MCP joint is evaluated. Now for the card test, a card should be used, and after that the patient is asked to keep fingers extended as well as adducted, and then a firm paper card is inserted in each wave space serially, and patient is instructed to grasp it tightly while the examiner tries to pull it out with the same hand and the same fingers as the patient's, and then the inability to hold the card tightly indicates weakness of the palmar interossei. Now for the evaluation of dorsal interossei and thus the deep branch of ulnar nerve, the patient is asked to spread out the fingers against the resistance by the examiner hands, and inability to do so indicates the weakness of dorsal interossei. For the evaluation of the extensors of the wrist joint, the patient is asked to dorsiflex the wrist against the resistance, and the weakness in while doing so indicates the radial nerve involvement. For the evaluation of lumbricals and interossei, the patient is asked to flex the fingers at metacarpopharyngeal joints against the resistance. And for the evaluation of the common peroneal nerve, first of all, the patient is asked to keep the foot on the ground. After that, he or she is asked to dorsiflex the angle against the resistance. After that, another test is to ask the patient to extend the great toe against the resistance. And finally, another test for the common peroneal nerve is the eversion of the foot. Now, to evaluate the intrinsic muscles of the feet, the patient is asked to adduct or abduct the toes against the resistance, and finally the gait of the patient is evaluated by asking the patient to walk in a straight line.